All right, so we're going to talk about the considerations in geriatric trauma. What you see on your screen is a flow sheet from EMS. I'm sure they're all different when you're looking at the EMS flow sheet, but basically it's going to tell you a story of what happened with this patient prior to coming into the hospital. You can see this is a 94-year-old male. They had a fall that was witnessed, and they're complaining of neck pain. So falls in the geriatric patient, even from a ground level or even from a chair in which they were sitting, can cause significant injury. So you have to be aware of that first off, and knowing that they are already complaining of neck pain, that gives you a concern as well. And then you add on the fact that this person has Coumadin on board for anticoagulation. And we're going to go through some of that. Their Glasgow Coma score is a 9. And we know that with the Glasgow Coma score, we're looking at anything 8 and below, that the possibility of needing to intubate the patient. But when we're looking at the Glasgow Coma score, understanding the baselines for the patient that may interact with their Glasgow Coma score that they have. So that's where the importance of history taking at the scene or from family members may come into play for this. The blood pressure is 88 over palp, 84% on 2 liters. And the only history that we have is that the person has a history of dementia, and they were diagnosed yesterday with a upper respiratory infection. So from this, you would get your lead-in story as to what happened with this patient and why they showed up into your ER. And you have to go from there. So some of the epidemiology and mechanisms of injury in the geriatric patients. As you know, in this area, as in most areas, we have a significant amount of population that are geriatrics in the rural areas. As we're looking at it, the geriatric population is increasing, mainly because we have much better care of the geriatric patient, and our patients are living longer. So therefore, the geriatric patient, even at 90, could still be out in their home, living by themselves, and they could still be driving a vehicle. So these are all the things that we have to start thinking about when we're trying to plan for the patients in our own community, what we would be treating them for. They have a higher morbidity and mortality with lesser injuries. As I said, when you go from a ground level fall and hit the floor in your geriatric, you have the risk of sustaining a hip fracture, which could end up with an increased morbidity and mortality for that geriatric patient. So it's much different, and it increases with the patient's age and their comorbidities. We also know that we under triage the geriatric patient more often than we would an adult patient. And that's some of the things that we're going to be going through, is making sure that we recognize some of those signs and symptoms that lead us to the fact that this patient is doing poorly. Some of the mechanisms of injury are falls, motor vehicle collision, pedestrian where they're walking across the street, assaults, including elder abuse, burns, and inhalation. These are all the things that we're going to touch on during this part of the segment. So this is our 94-year-old male geriatric patient. When we're looking at the geriatric patient, we know that there's a lot of physiologic changes. They have less brain mass, so their brain atrophies, and that's normal. The brain atrophy could increase with alcohol abuse and comorbidities that go along with the patient. But what that means to us is that atrophy, when that person hits the floor and their head hits the ground, the bridging veins that go attached to the skull are more likely to stretch and then break, so that they're going to end up with a subdural hematoma, even from a light touch on their head. We also know that with that brain atrophy, those patients can have an increase in bleed before we actually recognize that they have symptoms that are occurring related to the brain injury itself. So we have to recognize that when we're first doing our assessment. Their visual acuity and their hearing are less, so they're more likely to be injured, more likely to fall, secondary to the vulnerability of having the visual loss and hearing loss. Their respiratory and vital capacity is going to be decreased. So If you take into account the patient may have an underlying COPD, their lungs are already compromised, and then we have them fall, they hit the ground, maybe they were down for a period of time. That's going to decrease their vital capacity and their ability to take that nice deep breath, which is going to precipitate further injuries or further trauma sequelae. When we're looking at the respiratory and chest wall, they're most likely to fracture a rib secondary to ground level fall, which is going to further compromise their respiratory status. Their cardiac output is already decreased. They may have an underlying left ventricular decrease, which impacts their preload, and our cardiac output is affected by the preload. So any cardiac history that's associated with our trauma patients, including coronary artery disease, hypertension, atrial fibrillation, all those things taken into account can cause compromise for the trauma patient. Their total body water, when we look at it, up until about the age of 75 to 80, we're looking at a total body water of about 60 to 65%. And as we get older, our total water body is going to decrease to about 50%. As with all of our other functions, our renal function is going to start to decrease. And actually at the age of around 35, the renal function starts to decrease, and it's dependent on a lot of factors. It could be diabetes, it could be their congestive heart failure, it could be their poor blood pressure control, all impacts their renal function. And with their renal function already impaired when they come into the hospital, it's going to cause them more concern. When we look at the high-risk medications, and it's something that we have to do a little bit better at, we have to consider the medications that they're on prior to coming into the hospital. When we're looking at beta blockers, that is used a lot for blood pressure control or for atrial fibrillation, it's going to block or blunt the patient's own response to shock that is ongoing in their body. So you may not recognize that their body is going into shock because their heart rate is being blocked by the beta blocker. And beta blockers also can predispose the patient to hypothermia. So if we had a patient who fell out in the snow and laid for a period of time, it also predisposes them for the hypothermia. When we talk about anticoagulants, this person is on Coumadin. She does have a history of AFib, although that wasn't in the history that we initially got. But it's important to know why the patient is on an anticoagulant. And then you also want to know what their last values were, because this person who's on Coumadin is at a higher risk for a traumatic brain injury, higher risk for blood loss anemia, which can further compromise their shock states. When we look at the antiplatelet medications, which a majority of our elderly patients are on, that 81 milligrams of aspirin, it could be Brilinta, it could be other antiplatelet medications. Maybe they had a stent 20 years ago and they're still on their antiplatelet medication. These are all things that we need to look at because we need to know if we're able to reverse, first of all, the anticoagulant, or if we need to give something for the antiplatelet medication secondary to the fact that they do have a head bleed or they have a profound hypotension with bleeding that is occurring. When we look at diuretics, a lot of the geriatric patients are on some form of diuretics secondary to heart failure. These patients are already predisposed to being dehydrated before they come into the hospital, secondary to their comorbidities and secondary to the diuretics themselves. So when we're looking at their medications, we already know that they may be behind the 8 ball on their fluids, and we need to keep that in mind when we're trying to work this patient up. That's just a small list of the high-risk medications. There's also medications that the patient could be on that maybe are not appropriate for their age or hasn't been reconciled in a period of time. Or it could be that the patient just doesn't know how often they were taking their beta blocker, and it could be a beta blocker overdose because they took too many. So all those things you have to keep in mind for this population. When we're looking at the geriatric airway and breathing, we know that if you don't have the dentures in place for a geriatric patient, trying to bag valve mask that patient is going to be more difficult. It could be that their dentures are not fitting and they're loose inside the patient's mouth. When we're looking at the cervical arthritis, looking at the picture that's on the left-hand side of the screen as you're looking at it, cervical arthritis is going to cause a decrease in mobility for that patient in general, but also if you need to intubate the geriatric patient. So you want to make sure that you're aware of all these things when you're taking care of them. When you're looking at breathing, diminished reserve and chest injuries are poorly tolerated. So you have an x-ray there that has right-sided rib fractures. That's on your left-hand side as you're looking at it. So the rib fractures themselves in a geriatric patient who already has a poor reserve with their breathing secondary to COPD, and then you add some pain on top of it, trying to control their pain in a person who's never had narcotics before. They're unable to take a deep breath. They're going to end up with more complications from that 1 to 2 rib fractures, let alone multiple rib fractures that they would have. In addition to that, if they do end up with blood inside of their chest or a hemothorax, that patient, if that hemothorax isn't released or relieved, that patient could have a further compromise of their lung wall compliance secondary to the hemothorax being in there. The biggest thing is recognizing the potential for rib fractures in a geriatric patient with even a ground level fall and how it could impact them as they go on throughout their course. When we're looking at circulation for a geriatric patient, some may not become tachycardic related to their beta blockade. When we're looking at a normal blood pressure reading for a person who is on 3 blood pressure medications, that normal blood pressure of 110, 120 is probably hypotensive in that patient. So you have to keep in account that just because it's normal in number doesn't mean that it's normal for the patient. So looking at all your other signs and symptoms and looking at the patient to make sure that they're fully resuscitated and not just looking at the systolic blood pressure number, or not just referring to the heart rate because they may not be able to mount that response secondary to medication, or the inability to release the catecholamines related to their heart injury, their poor heart, or their coronary artery vascular disease. Aggressive fluid resuscitation may not always be tolerated in these patients. So with these patients, you have to give a little bit of fluid and see how that works for them. So given a full liter of fluid in a person who has a history of congestive heart failure is going to put them into more pulmonary compromise as the fluid backs up, and it's also going to preclude them going into CHF exacerbation. So knowing when you do fluid resuscitation, make sure that you're doing small amounts at a time to make sure that you're not overloading the patient. When we're looking at disability for a geriatric patient, the cerebral atrophy causes a slower symptomatic with an acute hematoma, and that's related to the atrophy that's inside of the head. So the brain's smaller. It's going to take a lot more blood to be able to compress the brain itself and cause the symptom changes. So you need to be aware of that. And it's going to take a little bit more bleeding to possibly cause that person to decrease their mental status. Chronic dementia or acute neurologic change. So when the person comes into the hospital and you don't really know if they have dementia, but they're having some neurologic changes, makes it difficult to assess the geriatric patient because some of these things look like it could be related to the traumatic brain injury, when in fact the person has severe dementia in which they're unable to answer questions appropriately at baseline. So knowing a little bit of the background, but also looking at the patient to see, to make sure that we're doing the appropriate thing. And spinal column and spinal cord injury with minimal mechanism of injury. So as I said, with these geriatric patients, we have to be aware that everything is decreasing, including their bone structure. So osteoporosis is prevalent in this population, and they could have, with a minimal, just tried to sit down onto the chair and fell onto the floor instead, they could have multiple spine fractures that go along with that. So recognizing that the small bump to the floor could cause them an increase in injury. Some of the pitfalls for our geriatric patients is failure to appreciate limited physiologic reserve, meaning that this older patient isn't going to be able to tolerate the blood loss like a younger adult would be able to. So that minimal blood loss may cause them severe hypotension in the geriatric patient. Recognizing shock in the presence of relatively normal vital signs leading to under triage. Consider the major effect of a minor chest wall injury, and reverse therapeutic coagulopathy, and recognize elder abuse. So some of the ways that we recognize elder abuse is much like how we recognize pediatric abuse. We're looking at those injuries in which there's multiple stages of bruising or the story just doesn't add up. And anytime that you suspect elder abuse, you want to report that on to the area of aging so that they can investigate. There's not just the physical abuse that goes along with our elders. We're also looking at the mental abuse, the financial abuse that some of them undergo. So you're looking for all those things that could affect the patient. And we have questions. We have an 82-year-old man sustained a ground level fall following a syncopal episode. He is not moving his right side and has fixed and dilated left pupil. His family tells you that he has atrial fibrillation and takes only one medicine. His international normalized ratio, or INR, is 6. What medication is he most likely taking? A is aspirin, B is warfarin, C is simvastatin, and D is multivitamin. All right, so we're going to close out that question. The answer is warfarin or Coumadin. It's the oldest anticoagulation that we have. Most of our older population is on warfarin for atrial fibrillation, DVT, clots. It's cheap medication that most of the patients can afford. Okay. Sorry. Tom did it for me before. Yeah, I got it. 90-year-old female driver of a car is stuck on her left side and sustains multiple left-sided rib fractures. She feels okay and has minimal pain. She asked to go home. The most appropriate management for her is discharge home, admit her to your Royal 9-bed hospital, transfer her to a skilled nursing facility, or transfer her to your referral trauma center. Okay, we'll close that one out. So this one we had several different answers for. So when we're looking at this geriatric patient, she's 90 years old. She has left-sided rib fractures, multiple left-sided rib fractures. She wants to go home. And that's going to be the biggest thing that most geriatric patients are going to say. But as we look at that geriatric patient that already has poor pulmonary reserve, they have rib fractures, they're not going to be able to take a deep breath. Their pain is not going to be controlled. Sending them home, they're going to decompensate at home. So discharge to home is not the appropriate way to go with this patient. And then we had admit her to a Royal 9-bed hospital. When we're looking at the hospital size, we're looking at, is that area hospital able to care for the geriatric rib fracture patient? Are they able to institute all the things that they need for pulmonary hygiene to make sure that she's able to take a deep breath? Do they have the equipment such as Duaneb with Metaneb that forces that patient to take a deep breath? Do they have the ability to treat that patient further, or if she starts to decompensate because of her rib fractures and ends up in respiratory failure? The most appropriate answer would be to transfer her to a referral trauma center. I can see why we would answer some of these questions, but the most appropriate answer would be to transfer to a referral trauma center. 72-year-old woman with Alzheimer's disease is brought to the emergency department by a private vehicle after being found wandering around in the snow. Her husband last saw her at their residence 3 hours earlier. She has no external signs of injury other than frostbite on her toes and fingers. Which of the following are important aspects of her initial treatment? A is removal of the cold clothing and application of dry heat for rewarming. B is rapid rewarming with moist heat. C is administration of intravenous antibiotics. And D is early debridement of the frostbitten areas. Okay, we'll go ahead and close out that question. So when looking at the review of this question, which of the following are important aspects of her initial treatment for this patient? When I first looked at it, I was thinking of hypothermia when I read the first part of the question. And then when I reread the question, because I was going between A and B for my answer, there was a rapid rewarming with moist heat. The correct answer for this one is listed as B, the rapid rewarming with moist heat. And maybe Dr. Dumeier can go over this one a little bit because I could see why both would be right. But removal of the cold clothing is the first thing that you want to do. But the application of dry heat for rewarming is not indicated. And if you look in the book, it says that you're using moist heat or a moist bath when you're rewarming, when you're looking at the injury of frostbite.
Well, specifically, the question isn't saying that the patient's hypothermic, she just has frostbite. So if you're a hypothermic patient, you might want to warm them, remove the clothing, but this is a treatment of frostbite, which is never dry heat, it's moist heat and rapid rewarming. So the question is treating the frostbite.
And that's how I finally came down to my answer, but I can see how maybe the question was a little bit misleading because it misled me as well. So some of the key points for extremes of age, understanding the unique anatomy and physiology at extremes of age is essential to provide optimal care, and it is essential to have age-appropriate equipment and medications for our patients that are geriatric.